Good morning, everybody. I'm here all the way from Delhi, but then I know there are people all the way here from so many different countries. And on behalf of the Ministry of Health and Family Welfare, may I please welcome all of the delegates who are here from so many different countries. So thank you so much for encouraging the PA program and the PA professionals here. An immense gratitude on our behalf to all of you. If it's okay with you all, I don't know how much time I have, but what I'm going to do is do three things. I'm going to tell you a little bit of a story, okay? Story of how we got here and what we've all been doing and how this journey has been, because stories are always nice, right? Everybody loves stories. I'm going to tell you what the story has led to. So what's the actual work that we are doing in the government, because that's what everybody wants to hear, right? We are the people who are beaten up at all times because we don't seem to do enough. So before we get beaten up, I thought maybe we can tell you what is actually happening. And finally, I would like to end with what we expect, or rather where we would love to collaborate and get the support of everybody here in this room, the various different stakeholders. Does that sound like a good plan? Yeah? Okay. Great. So I'll indulge a little bit, if you indulge me. I'll just tell you a little bit about my personal story and why I even got sort of interested in this whole group and how it's become a much larger vision today. So I actually went to school, I did my initial graduation here, but then went to school to the United States and did health policy and administration, did my PhD, did my fellowship. And 10 years of working in the US, running many hospitals, setting up hospitals from scratch, came back to India in about 2010-11 and was appalled that there was no physician assistant. There was not a radiographer that was actually doing, let's say an ultrasound. There was not an ultrasonographer. There was a radiologist spending his precious time, 45 minutes, trying to do an ultrasound on a baby, on a pregnant woman. There were so many professions that I did not even see anywhere represented that it was actually shocking for me. And sort of the inefficiency of the system was sort of, really sort of glaring. At that point, I worked with, when I'd come in, I actually joined a think tank, which I'm sure you all heard from Professor Srinath Reddy this morning. He was my prior boss, so I actually worked with him for 5 years. And when we actually wrote a report called From Paramedics to Allied Health Professionals. So we wrote this report, which came out in 2011-12. The then government released this report. And that time, we characterized all of these professions who we said don't have a home, they don't have an identity, they don't have a recognition. So what are we going to do with all these people? What do we do? So that report, just FYI, right, and tells you what it takes in terms of time for change. 2011, that report was released. We are sitting today in 2023, and now we finally, we've moved so much, of course, which is great. I'll tell you the story of that journey. It is a very, very long journey. And it literally, you have to take a nail and a chisel and keep chiseling on it every day, a little bit, little bit, little bit. And that's where the work of all of the technical people, the policy people come in. Because, you cannot expect a bureaucrat or an administrative person to be sitting in that role. Their roles keep changing, and their agendas will change as quickly as their roles change. So it's very hard to expect a joint secretary or the secretary of health or anybody even in the state, because they've forgotten the subject. They've been taken and, put into, aviation or, petrochemicals. What are they going to do? So really, it is up to everybody here, and all of us technical and professionally qualified people and the people that have interest in policy to keep this flame burning of sorts. And I think that was really the work that I took upon myself to say, how do we break away from medical dominance and go into truly multidisciplinary care? And I think India has made a huge, huge progress in terms of where we are today. Because I sit in all of the policy circles, and I can tell you today, we have the most eminent circles in which everybody is talking about allied health professionals, nursing professionals, nurse midwives, line by line, and literally on the same tone as we're talking about doctors. So it's a huge, huge win in terms of just that paradigm shift, but it's only begun. And we are very, very fully aware. But please give yourselves a big round of applause, because I think all of you have really worked so hard in terms of just keeping this flame going. And I'll give you a little bit of the statistics and some of the issues of where we can say that this is indeed a reality. So, like I said, we came back, we wrote this report. 2-3 years later, we had set up a technical support unit within the ministry, and we said, what do we do to make this real? What do we do today? We have a report. The report is sitting on, the secretary's desk. It's got a nice coat of dust on it, and so the dust keeps getting removed once in a while. Somebody comes and dusts it off, as it happens with many of our reports, right? So while academically we write the report, we do the thinking, it was just very interesting for me. I call it, like the cat has 7 lives. I think this is my 3rd life. So the first life was running hospitals, right, in pure operations. Second life was actually in this academic think tank where we said, what do we do? What do we think? But then one of the very, an extremely visionary secretary that India had, Dr. Keshav Desiraju, he actually passed away a few years ago, actually a couple of years ago during COVID. But he was this visionary who said, we want a technical support unit within the government that will come in and tell us how we can move this entire agenda for human resources for health forward. So when you have a good report, can we try and see what we do to actually make it happen? Because guess what? We don't know how to make it happen. And trust me, that takes a lot of humility, right? That takes, because most bureaucrats will never tell you. But this was a man who said, you know what, we want to have people who understand policy, who represent these various professions to sit inside the government and tell us how to do this so that we can make this happen. And that's when we set up this unit within the ministry in 2016, and we called it the National Human Resources for Health Cell, and this was supported. So this was a WHO and a Government of India Ministry cell that's set up, and that's the cell that I've been leading now for the last several years. And the advisory in that cell really is to look at all of the various professionals, not just doctors. So some of the big reforms, again, I'm telling you all of this because there's so many students over here. As you work in the health system, it's very important that you understand what part of that system you constitute, right? Because you can't only look at your role and say, oh, I am the PA, so that's all I care about. You cannot. And we've heard from such eminent speakers, and you all have done such a great job. And thank you, by the way. I was so apologetic. My flight was ridiculously delayed, so I was very late. And I didn't make it here at 10 o'clock, but I'm glad because I could hear some excellent comments. And I think I know, as when I go back to the government, and I know what are some of the things that we need to continue to work on, or some responses to some of the questions that were raised by, some of the people here in the audience. So I'm actually very glad that I got to hear that session, as opposed to just come in and, give you some wisdom of what we are already doing. So anyway, so when we set up this unit, we said, how do we take this beautiful report and can we convert it into legislation? Can we convert it into regulation? Can we convert it into an act that will actually start empowering each one of the people that really haven't found a home? And it was, I think, 2013 or 14 when I had heard the word that I was absolutely flummoxed to know that we did have PAs in India, because one of the very senior doctors at that point, Dr. Shiv Chaudhary from the All India Institute, he visited me at PHFI and said, do you know about this cadre? I said, well, I know about this cadre in the US. I don't know about this cadre here. He said, guess what? We have a small group here, and we're training these people in so many places. And that's when we were determined to say, this group has got to find a place inside this bill and has to, the number of people that said, what do these people do? Who are the PAs? What do they do? But I think you have a great advocate in your group, in the IAPA, and thank you so much, Shiv Kumarji, because you have been so persistently advocating this over the years, and to the whole group of you. I know you have, a great group of committed PAs. I think I'm a standard feature. I think every time they just decide, when they put the conference together, they just say, let's just go ahead and, make sure Kavita comes in and tells us some story. But I really have loved being a part of this journey all over the years, because we are very, very committed to ensuring that the PAs find not just a role, but a very specific role in ensuring that task shifting is actually happening. We've heard such, incredible stories. We have some organizations doing great work on the ground. And it is indeed true that there is a massive shortage, right? So we know that now it's interesting, right? Because we don't have a shortage in terms of the number of bodies. We actually have in India, just for some context, because I actually keep the data for all of the, HRH for India. That's one of the things that our cell does. We have close to 7 million in the health workforce. That is 70 lakh people that are actually captured in the health workforce. So that's not a small number. In fact, using this number, we were actually able to get India off of the shortage list. The WHO has a global workforce shortage list. And, I went along with one of my colleagues, and we made this case and said, you know what? We don't have a shortage of people. What we need is specifically what, some of the speakers earlier alluded to. We need competencies, we need skills, and we need to be able to map it exactly down to who is doing what, and that's the key. And if we can make somebody competent, I think that was Dr. Vora who was saying earlier, it really doesn't matter who you are. If you are so good at your job, you will get a seat at the table. I am convinced of it, and I have seen this happen. And I promise you that, that's where our Achilles heel really is there now. And we are making a lot of strides, and I'll tell you some of the things that we are doing right now, in the Government of India, where we are trying to move this. But we have to also appreciate how complicated a machinery the government is, right? This is a very complex country. For all of you who are here, from many parts of the world, and have been to several of your countries, thank you to all of you who are here. You all have done this work for many years. So do guide us, do share some of your wisdom with us. But for us, every state, I call ourselves actually, we are like the EU. We don't have a Brexit option, right? Nobody has a Brexit option. But guess what? We are like the EU because we have these 36 states and UTs that are completely different. They think differently, they wear different, clothes, they eat different food, and they culturally think very differently. They learn differently. They therefore make decisions differently, they communicate differently, and yet we have, we are trying to make regulations across the country. So it's very, very complex. And the complexities and the differences are much larger than what we could appreciate from outside, because we say, oh, they're all speaking English, great, must be okay, they may all just work. Not true. So some of the things that we are doing right now in the interim commission, and I'll come to it, will sort of tell you how much work is needed to really get this standardization done. So one of the things that we did in 2018 is a very major move. This government, when it took over in about 2014, I guess, one of the things that it committed to was universal health care, right? It said we will give coverage, there will be quality, there will be care, and there will be access to everybody. And the Ayushman Bharat program is actually one of the world's largest health insurance schemes, as you know, and this is aimed at that. But right? Even as we know and we do it, we know all of the challenges that come with it. And the biggest challenge there has been, how do we create this workforce? How do we motivate them to go down to every rural center? So while we have the 150,000 health and wellness centers, we still struggle to find the doctor who will go in there and stick there, right? So this idea of multidisciplinary care and task shifting really gained, I think we were able to make headway in making the policymakers understand this has to change. We don't have enough doctors, and we will never have enough doctors to be able to go down and fill every health and wellness center. But can we open our minds to looking at some of the more professional cadres, right, who can go down and be skilled enough? Can we tell them exactly what they can do and exactly what they cannot do? I think that's very important. So we developed something called a never list. A never list is something where you will not do this. So if, when in doubt, you have at that point got to stop. Because we also have an issue in India, because of not having enough doctors, there is a huge problem of, sort of what we call I won't call them quacks anymore, but these informal providers who all sort of assume the role of a doctor, right? So they use a little, indigenous medicine, some Ayush, something else, take a few pills that they know they can prescribe without prescription, and lo presto, you're a doctor now. This is a major problem that has been, there. But guess what? They are the point of care in rural India, because that poor guy who is sitting somewhere inside and who has to travel 10 miles before his wife can actually see a doctor has no choice but to go to whoever is in there. Can we solve that problem by putting qualified nurse practitioners, qualified PAs who can work at the primary care level, qualified, we speak about the CHOs. While these are challenges, while it's not easy to get them there, this is the answer that I think now the government is extremely accepting of, understanding of, and willing to adopt, as long as we can make it happen. I think the challenge is really in the implementation, because it's not a joke, right? It's easier said than done when we've got to staff so many. So there is, I very interestingly, I attended a meeting 2 days ago, which was chaired by the GAPIO, which is, I think, the Association of Physicians of Indian Origin, and the APIO. So these are American physicians of Indian origin, several other countries. There were physicians that came in, and they were probably India's top 10 physicians, and it was being chaired by Dr. Vinod Paul. Dr. Vinod Paul is a member of the Niti Aayog. He's a very big proponent and a champion of the PA program, by the way. And he asks me virtually every week when I meet him, Kavita, when in India will you give me 2 lakh PAs? I said, sir, we are waiting to give you 2 lakh, right? I mean, 2 lakh, the number, 200,000 physician assistants is what he says we need as of yesterday. And you are at 6,000. But please give yourselves a big hand, because guess what? We are trying to find a way to clone you all. Maybe we can just find a cloning medicine and, clone you all and put you everywhere. But we realize that the challenge, right? How do we ensure that we get quality people that are trained in 4 years? Because it's not a joke. We can't take you and put you out in 3 months and 6 months and say, guess what? We created so many people. So while quality is kept up, while standards are kept up and competencies are kept up, we totally realize what a huge role of supply creation that's actually upon us, because it's indeed a mammoth task. So we need people to go, and our appeal to the private sector was to actually put the funds and say, please come on and invest in building, like you build medical colleges, like you build others, please build the institutes so that there can be more people who can be trained in this very, very specific role. People, where we can have, we recently had the act also passed called the National Nursing and Midwifery Commission Act. I've worked on that particular bill for about 5 years, and finally that saw the light of day. But I can tell you that this act, the National Commission for Allied and Healthcare Professions, was an act that took 75 years, because the work on it started, the first advocacy for it started in the year India got independence, in 1947. Because a regulator came for doctors, the regulator came for nurses, it came for dentists, and it came for pharmacists. Everybody else was just left off. So this whole group of people just had no home. 75 years it took for them, for this act to basically become law, for this bill to actually become law. And finally in 2021, after endless advocacy, and again I have to thank Shiv Kumarji and a lot of the PAs who were actually called to Parliament in order to come in and give their comments as to why this was important, right? So you have to go in and you have to give your testimonies over and over and over again. More than 700 stakeholders were called across the country. We made 58 drafts of the bill, and I personally drafted every one of them. The 58th draft of that bill became an act. And so I think on the day that it got passed in both houses, we had a collective, there were people just burst into tears, because we just, at that point we said, okay, I think we are done. I really thought I could get enlightened and, get my nirvana and go away. But then you realize, well, it's only the beginning, because the act is nothing but just, you've just said, okay, here is an act. How do you make this happen? How do you make this real? And that's the point that I want to now spend some time talking to you all about, as to what is it that you're doing. Because you can say, okay, madam, you keep coming every year and you keep telling us this story. And you said, okay, it took us so long when we got this act. Now what? Now tell us, how are you standardizing? What are you doing? How do we know we really have an identity and what's going on? And that's what I'd like to tell you about, so that you all feel comfortable and you also feel confident that you're, even though we only address you once a year, but there is a lot of activity that's going on, to make sure that this is happening. So the Interim Commission for the Allied and Healthcare Professions was the body that has been set up immediately. So the moment the act was passed, the Interim Commission was set up. The National Commission should be up virtually in the next few months, anytime. But the Interim Commission has exactly all of the roles of the National Commission. It is currently headed by the Additional Secretary that is in charge of medical education, etc. And her work as a chairperson, along with, we have members representing all the various groups. And what we are doing is doing 3 major pieces of work. We are trying to register every allied and healthcare professional onto an enrollment database. We are not calling it registration yet. Guess why? Because we don't know. For PAs, maybe there are a few very good schools. There are many professions where we have no idea which school they went to. We don't know if the college exists, or whether it's a building, whether it's a virtual, something in a black hole that we are not aware of. So until we get a database of every single institute that is actually running programs, and somebody can go in and validate the authenticity, the quality, and the competency of that program, we are not willing to rush this at this point. Having waited 75 years, if we, rushed it and just put everybody in there just to show a number, I think it would be a fallacy. So I think our goal is really to say we will take this systematically forward. We will create a database of all of the institutes in every state that is actually running a program. So one area where you can really help us is, possibly, and I'm going to look to Shiv Kumarji over here, is if a list of all the institutes that you think are valid, okay, or people where, even if they're working outside, wherever, if the list of institutes which can be put on our register immediately because they're just doing good work, we can immediately take that and at least look at it and add it to our drop-down box so that somebody can go in and look at it. Similarly, we are in fact going to do like an enrollment drive. So in every district, right, we have more than 740 districts in this country, but in every district we would like to do like a kiosk where somebody can come in and go in and fill in all of their details, right? And the details would be, where are you from, where did you study, what's your main qualification, can you upload your degree or your certificates, do you work now, just some basic information. But we, in the last 2 days, the reason I couldn't even come here earlier is we've had I think the 3rd or the 4th general body meeting of the Interim Commission, and all the members have sat in and day out, going through every single field, ensuring that we get this enrollment ready and ready to be rolled out, right? Both for institutions and for professionals. And the professionals listed in the National Commission are 56 in number. There are 56 types of professions. In the medical, so all of the technologists come together, and where the physician assistants are. Unfortunately, right now, we do not have a representative from the PA program in the interim commission. However, that will be fixed, because in the main commission, of course, they will be there. But this is where I want to again tell you the role of advocacy. So all the names for all of the people who constitute the commission are only by nomination. And the nomination happens by state governments. So we need you to engage with states. We need you to go out and tell the states, like you are doing. I know you're doing it in a few states. So let the state government tell us, we need this particular person, we need 2 of these people, and then it makes our life very easy. Because the central government at this point cannot just pick somebody and say, I like you, I know you are doing great work, you know what, I'm just going to put you on there. That doesn't work that way, right? So there is a nomination process. So the advocacy is important, so that somebody can tell us, here are these 2 people that are doing excellent technical work. And please remember, the work of the commission is not political. The work of the commission is absolutely technical. It means looking, it means pouring through curricula. We've done this, pouring for at least the 7 curricula that we're already looking at almost finalizing. We have brought the best of the best curriculum from all over the world. We've looked at it and said, where can we create one that meets not just India standards, please note, but can it meet global standards? I think this is very, very, very important to note. So again, it's something for all of the people here who are here from the various countries, because we hope that our PAs can go everywhere. We really do hope they can go to the UK. We hope that they're in the US. We hope that they're everywhere. So not only are we trying to create the PAs for India, but really we want this group to grow so much, because there's so much potential that we see. They're just not growing fast enough. We're really trying, but it's not growing fast enough. So the work of identifying the good work that's already being done, I think, has to be captured. So there is the role, like we were talking about roles, every academic institution here, whether it's IIPH, whether it's all the associated, whether it's any of the other partner organizations, please find us the evidence. I think you all spoke about this already. If we can get evidence on how do we actually move this forward, how do we actually make, change this, this is very, very useful. So particularly, I think Dr. Santosh Matthew, who's been a great friend at BMGF, we've done some incredible work on this whole competency mapping during COVID. We undertook a massive exercise, and we did this during COVID because, what are we going to do with 1.4 billion people we need to take care of? I was actually running the whole, HR unit at that point. And we were given 30 days to train almost 3 million people all over the country, right? It was just everybody on Zoom, district by district. We're training people, sending things and saying, get ready, because guess what? You just got to do the work. That's when the real idea of multidisciplinary care seeped in, because doctors saw and the health system saw how beautifully so many others were able to step in and do the things that was never done before. So COVID for us was actually a great, it was a great learning opportunity, and I would call a great time for it to make that paradigm shift happen for the health system. So we are very grateful from that standpoint. So today, if there's evidence on saying we can task shift and X, Y, and Z can do this work very well, do a suture, like somebody was saying, can go in and, put in that, the splint, can do a whole bunch of things, and we do not need the doctor. Please, let's get that evidence, and let's continue to feed the evidence to the people who need to see it. In terms of the private sector, I don't think there's anybody here from the private sector, but the private sector, and we've told them this, needs to invest in infrastructure, needs to invest in skill centers, needs to invest and put their money, where their mouth is in terms of saying, how do we skill and make people competent? Which means, how do we make sure your hands can do what you're saying, not just about looking at a curriculum. So, right, it's about saying it's more than the curriculum, because you'll find that there are many people who are fantastic when it comes to the didactics and the theory. When it comes to actually doing what you have to do on the patient, are you comfortable? Are you confident? And please note, when we give you a license to practice, we mean it when we say it's a license to practice, which means you are also now liable for everything you do. You cannot hide behind the doctor anymore. Are you willing to take on that liability? You can only take on that liability if you have that level of expertise, right? So am I willing to go that role and do what I need to, and also be accountable for whatever happens then? So that's the point there. And I know we had some discussions on, doctors it'll take a long while for doctors to, for us to get on the table. I can assure you that's changing. So we are pushing as a government for the role of nurse practitioners, for the role of nurse midwives. for PAs, for physiotherapists, optometrists, to all be there to independently work. And the regulations that will be drafted will definitely be looking at it. So it doesn't matter, so the National Medical Commission can continue to say no, no, no. But there'll be a list of things that once everybody feels very comfortable, that a certain professional can execute on independently. And as long as there's demonstrated evidence of his or her competency, I will keep using that word over and over again because that's the only measure by which we can, finally ensure that there is a quality health system. I think everything else is a farce. I mean, everything else, somebody saying I have a curriculum, I have a book, I have a great institute, I don't care. Because if the person that comes out of your institute doesn't know what he or she is doing, I mean, I really don't care where you taught him or didn't, right? So I think that's the key, and that's a change in paradigm. That's not happened in regulation before. Regulation has meant, a big logbook, a lot of lack of transparency, nobody will know what the data is. It's gone away with digital. We have actually just made a resolution 2 days ago in our meeting that everything will be digital, which means I will self-report everything I'm doing. The whole thing will be digital. So there is no more question of saying, I'm going to go into an old book and look up, if this person is dead or alive or whatever. If you're dead, well, guess what? You won't be entering that information. So hopefully you won't be there, right? So it's a live register. So we've called it specifically a live register because we want to ensure that if you're going from one state to another, your data travels with you. That it's not just you traveling, that you're not registering at 5 other places, that you're actually going to be, the data travels from one to the other. So there is a lot of thought going into the registration of both institutions and individuals. I'll come to curriculum. Again, tons and tons of work, experts sitting together to look at curriculum. Clearly, we don't have an expert group yet for the PAs. But my boss, the Secretary of Health, has charged me with saying that within the next 10 days, he wants the group set up for every other group as well. So not just for the 7 or 8 that we've been working on. So the PAs, incidentally, we have already had a curriculum, a draft curriculum that was drafted a few years ago, 3-4 years ago, but that was sort of again lying down because, there was no regulator to take it up. We are going to now clean the dust off of that one, pull few comments. I would really encourage several of the, international faculty that are also here to please, maybe, we are going to invite you, and I've spoken to Shiv Kumarji to find a way to connect, you all with us as well. And we are going to invite you to please come and look at some of that and create for us, help us create not just PAs at the tertiary level, but definitely PAs at the primary care. And please, I really want you all to share your experiences with us and see what is it that they can do, where can we put them, because I assure you we will push in the Indian public health standards and create a post if we have to, right? And we will say, here is a post of a PA. The problem right now is if we create the post, there is no body to put them in. There is nobody because everybody's already out. They're all over the world. The jobs are gone before they even came out. So until we have enough of a production, it is, would be a little bit fallacious to go ahead and put them in there. This is a challenge. So we need a quick production because the demand is definitely there. There is no question. There is not going to be a PA that's going to come out and say, I don't have a job. I'd be like, that would be very, very shocking. So please give yourselves a big hand because we really need you to multiply and really need you to grow and really need you to be the leaders who will, take a lot of this forward. So like I said, curriculum is very, very critical for us. We want the curriculum to match international standard classification of occupations. The ISCO code, which is on the WHO, and the International Labour Organization, the ILO, these are the 2 codes that we follow for all nomenclature. And this was specifically our work that we did with the WHO during the passage of this act. So nobody, which is why we changed the name to physician associate. We did not want to call, people physician assistants, even though it's understood here, because we rearranged the entire paradigm at the lower level and said skilled workers would be maybe assistants, but skilled workers, please note, not professionals. But if you're above that and you're going through a 3-4 year program and going through something very, very detailed, you will be an associate. So therefore, we have actually named, the physician assistants as physician associates, and I hope that that will be the nomenclature that will then get the equivalence wherever, whenever they've got to come into. So that will be the, that will be what it will be said on their certificate or on their license when it comes in. There will be a provisional registration process, like I mentioned. So first will be the enrollment. So everybody will get enrolled on that process, and we will have to put a group to come in and say, hey, is this person qualifying? Is so-and-so good? And that's when, once the certain check of their institute and qualifications have been done, they will get a license to practice. There was a question asked earlier about CME/continuing education credits. So as per the Act of 2021, every 5 years, you have to go ahead and make sure that you have enough educational credits so you can renew your license like any other professional. So if you're, sitting at home or saying, I'm not touching a patient for 10 years, you will not get a license again. And I think it's only fair. I don't think you would want to be treated by anybody that hasn't, seen a patient for a few years. So once every 5 years, you've got to give in your credits, and that's how it'll be, like it happens for any other major regulator in the world. The regulations for it will be done when the council actually comes up. So right now, we are at the interim commission. Like I said, any moment now, within the next few months, we will have the national commission under which 10 professional councils will be set up. And in one of the councils, right, basically in the medical technology group is where, we will have every group represented there. So you will also get your own group will come in, and we hope that many of the smart people in this room we see on that council, both at the international and the national level, so that we use your commitment and your expertise to build the program for this entire country. Because I can assure you that there is a need, there is a desire to sort of engage, and there is actually, we just need this for patient care. It's very simple. If you've got to make universal healthcare a reality, without question, we need all of you in the system at all levels. So we really, I'm going to sort of stop my piece here and open it up for any questions that I'm sure a lot of you have, to say that this is indeed momentous for us. As I was sitting there, and a lot of the members last week were complaining, going, oh my God, we haven't done enough, I said, can we stop and pause and actually just pat ourselves in the back once? Because we've actually achieved a lot. And I really think this is a big moment. A big moment because you all have come through this, you've stuck to the program. You have not quit and suddenly decided I'm going to go, be working as a, media design person. And there are many people who do that, right? They suddenly say, I'm tired. I'm just going to go off and do something else. There are many lab technicians, for example, who've quit and done that. Please do not quit healthcare. It is the most important, most rewarding, the largest growth sector that at least this country and probably the world is going to see in the next several decades. I can assure you of that. That's where this is. You are truly the healers. You are the people who are going to make the difference, not just at a clinical level, at a society level, at a community level. And there are great leadership opportunities coming for you to really make change. So please stick to the profession. Make sure that you do the best, do your master's, do your PhD, study and be so good that you will be at the table next to anybody else, not because somebody is a doctor, not because somebody is a nurse, because you have just done the highest level of work in your profession. So I am convinced that there is a possibility to do that, and I really look forward to supporting this group and all other groups in making this vision for India and for the world a reality. Thank you so much.